of the pressure. So signals to the spinal cord and then the subconscious level, and telling you to, it will give a motor response unconsciously. You will move to the right, uplifting the left buttock para magkaroon lang ng konting perfusion. And then a few minutes, you will move to the left. Parang ganon. So unconsciously, you do not know that you are actually moving, and this prevents from decubitus ulcer. Unlike in patients with stroke or spinal cord injury, wala na yung ganitong mechanism, and that's why they are high risk to have decubitus ulcer. Another example here in terms of pathophysiology are patients who are diabetic if they have peripheral neuropathy. Hindi na nila nalalaman na meron na palang silang sugat sa paa until pagtanggal nila ng shoes, malaki na yung sugat, malaki na yung ulcer. So these are the situations telling you how important pain for our survival. That's why we will talk more about pain sensation. So there are two types, fast pain and slow pain. So kailangan yung ma-memorize to. At first, memory lang muna, and then you read more, and then it will be cemented in your brain. It's also described as sharp pain, pricking pain, acute pain, electric pain. So fast, sharp pain is not felt in most deep tissues of the body. More on superficial lang siya. Whereas slow pain is slow burning pain, aching pain, throbbing pain, nauseous pain, chronic pain. So kung fast pain, acute, slow pain, chronic siya. So this type of pain, yung slow pain, is usually associated with tissue destruction and can be superficial but can also be deep. So fast pain, superficial only. Slow pain is deep. Fast pain, acute. Slow pain is chronic. So fast pain, yung with less than 0.1 second, yung stimulus will reach to the subconscious level. Whereas slow pain, umaabot pa siya ng more than 1 second to a few minutes. Kaya, all right. Once there is a pain stimulus, it will stimulate the pain receptors. And all pain receptors are free nerve endings. It can be stimulated or excited by mechanical, thermal, and chemical. So pag fast pain, mechanical and thermal lang. Pero pag slow pain, mostly chemical but can also be mechanical or thermal. Ulitin ko lang, fast pain, it will be stimulated by mechanical or thermal stimuli only. But yung slow pain, mostly chemical but can be and thermal. So tatlo yung slow pain, dalawa lang si fast pain. So the types of chemicals that can stimulate pain are bradykinin, histamine, potassium, acid, acetylcholine, or perculytic enzymes. Prostaglandin and substance P are also chemicals that can increase sensitivity of the pain, but not directly the pain receptors. Okay? There is what we call as non-adapting nature of pain receptors. Sa ating term, sabihin na lang natin ang tao, hindi tayo manhid sa pain. So it means to say that, for example, the intensity of pain, if you are exposed to pain, for example, for an hour, yung intensity of pain will be the same for 1 hour. Hindi siya like after 30 minutes, pahina na siya ng pahina. So as long as the intensity of the pain is the same, it will be perceived as the same. Hindi siya hihina. Because the pain receptors are not adapting. In fact, it can increase but not decrease. So if the sensitivity increases, that's what we call as hyperalgesia. So for example, after 30 minutes, bumaba na yung perception ng pain, it means to say that the source of pain or the pain intensity actually decreased, not because nag-adapt yung pain receptors. So I hope that is clear. So this non-adaptive nature of pain receptors is important for our survival. That's because as long as the pain is still there, you will do something to alleviate the pain. You will try to look for the source of pain. Unlike kung nag-a-adapt yan, pahina na ng pahina until wala ng source of pain, then you will just realize later on ang laki na ng tissue damage. pain is actually important for our survival. All right. So the rate of pain, di ko mabasa, no? Kasi nandyan yung face niyo. Okay. So the pain is, the pain resulting from heat is closely correlated with the rate at which the damage to the tissues is occurring and not with the total damage that has already occurred. So if you look at the graph, at 45 degrees Celsius and beyond, it can cause a greater damage. It can cause a greater tissue damage. And that's why, pagdating sa 45 degrees Celsius, sobrang taas na ng intensity ng pain. And it will protect you. Kasi if you try to prolong the exposure from heat at more than 45 degrees Celsius, there will be a greater damage. Okay lang, thank you. So, yan yung ibig sabihin nun. The intensity of pain is also closely correlated with the rate of tissue damage from causes. So, it's not from the size of the damage, but the rate to which the stimulus can cause damage. So, the special importance of chemical pain stimuli during tissue, sinabi ko na kanina, we have a lot of chemicals that can induce pain, but bradykinin is the agent most responsible to cause pain. Tissue ischemia can also stimulate pain, and this is because there's accumulation of large amounts of lactic acid, bradykinin, and proteolytic enzymes. But the greater the rate of metabolism of the tissue, the rapidly the pain appears. So let me explain. So for example, you put a cuff on your arm, left arm, and then you inflate it to, let's say, 180 to 200 millimeters mercury. It will cause a decreased blood supply to the forearm, and yun yung magkakos ng ischemia. So as long as the forearm is steady, you will feel pain from ischemia after, let's say, after a few minutes pa. Whereas if you try to flex the forearm or the wrist, the pain will be felt within 15 seconds. And that's because you have increased the metabolism of the tissue. So increasing the imbalance between the supply and the demand. All right. Another example is in myocardial infarction. If the heart rate is so fast, okay, it will increase the pain, the chest pain more as compared to a patient who have a heart attack, but the heart rate is between 80 or less than 100 beats per minute. So again, and increasing the rate of metabolism of tissue will increase pain, and that's because you aggravate the ischemia, you increase the size of the ischemia, and of course, ischemia itself will stimulate. So muscle spasm is also a source of pain, and alam natin yan pag nag-gym, you over-exercise. During that time, after the exercise, you will not feel pain, but after a few hours, you can have pain from delayed onset muscle spasm. So I hope you are familiar about that. And because muscle spasm increases the rate of metabolism in the muscle tissue and can stimulate pain, right? Okay, so there are two types, the fast sharp pain pathway and the slow chronic pain pathway. So the fast sharp pain is mechanical or thermal. Again, wala siyang chemical, and this is transmitted by small type alpha delta fibers at 6 and 30 meters per second. Take note, it's so fast to 30 meters per second velocity. The slow chronic pain naman is mostly chemical, but can also be mechanical and thermal, and this is transmitted to the spinal cord by type C fibers, this times lower velocity at 0.5 to 2 meters per second. So you just have to be familiar with the anatomy. The alpha delta will decussate at the same level of the spinal cord into the anterolateral pathway in the same way that the C fibers will also decussate at the same level of the spinal cord into the anterolateral pathway. So the fast pain is via the neospinothalamic tract. Once it decussates, it reaches into the into the thalamus up to the cortex. It will travel via the neospinothalamic tract. From the lamina 1 of the dorsal horn, it will cross to the opposite side of the cord through anterior commissure to the anterolateral columns, then towards the ventrobasal complex to the cortex. Sobrang hirap niyan, but wala tayong choice. We just have to be familiar. What's important here is that you have to understand where this tract, where this fibers decussate. So it decussate, it crosses at the same level of the spinal cord, unlike in corticospinal tract or dorsal column that decussates in the medulla. So in terms of identifying the source of the injury, it will help you if the disability is either contralateral or ipsilateral. Okay? Fast, sharp type of pain can be localized. Yung fast, sharp pain is specific. It will tell you which is the source of the pain. Alam mong nasa rings, yung nasa index finger yung source of pain. The slow pathway naman uses substance P, and it is projected via the paliospinothalamic pathway into the brainstem and thalamus. This time, slow chronic pain is not specific. You just know that the source of the pain is from the right upper extremity, but you are not sure if it's in the index finger, unlike in a fast sharp pain. Okay? So just to review, fast sharp pain is specific. It can localize the source of the pain. Slow chronic pain has poor capability to be precise of the location of the source of the pain. Okay? So paliospinothalamic tract into the brainstem and the thalamus is projected into the reticular nuclei of the medulla, pons, and mesencephalon. The tactile area of the mesencephalon deep to the superior and inferior colliculi, or the periaqueductal gray region surrounding the aqueduct of Sylvius. I will talk a little bit more of the periaqueductal gray region later. Okay. Ito yung sinasabi kong most of pain sensation is in the subconscious level. But it doesn't mean that the cortex is not important, because a few percent will still be transmitted into the cortex to interpret the pain quality. The cortex is important in interpreting the pain quality, whereas most of the pain sensation is up to the subconscious level or the lower center. Okay. We have now understood that the arousal site is in the reticular areas and intralaminar nuclei of the thalamus. That's because the pain terminates in this area. And if there is a stimulation of pain, will actually arouse the patient. And that's why clinically, if we see patients who are in pain, they really cannot sleep because the patient is aroused. So, for example, we have a patient conscious. We try to arouse by stimulating through pain. Yung either iniipit yung kamay, ganyan, or nirarub natin using our knuckles, nirarub yung chest area. And so that's to arouse the patient through pain. Okay. So ito yung pain system or analgesia system. Merong mga taong, alam mo yon, ang taas ng pain tolerance nila. Merong mga taong low yung pain tolerance. So for example, a patient looks okay, sabi niya parang tolerable lang yung pain, and then pag-opera, ruptured appendicitis na with peritonitis. Ito yung mga taong high pain tolerance. Meron namang mga taong inflamed pa lang yung appendicitis, sobrang severe na yung presentation na. So they have low tolerance to pain. And the explanation behind is some patients or some individuals have a pronounced analgesia system, while others hindi maganda yung analgesia system. So let's talk about this analgesia system. So it starts from the aqueductal gray and the periventricular areas. In between the third ventricle and the fourth ventricle, there are neurons, first order neuron, that will go to the nucleus raffimagnus, and then synapse with a second order neuron out from the nucleus raffimagnus into the dorsal horn of the spinal cord. It will synapse the inhibitory interneuron, and this inhibitory interneuron will now inhibit the pain receptor neuron. before the pain receptor neuron are inhibited before it actually enters into the spinal cord up to the spinal or the thalamic area. So it inhibits the pain at the spinal cord level. Kaya hindi mo na mape-perceive yung pain. Okay? The first order neuron from the periaqueductal gray and the periventricular areas uses enkephalin as a neurotransmitter. The second order neuron from the nucleus raphe down to the dorsal neurotransmitter. Okay pa ba yung signal? Hello? Naririnig niyo pa ako?
Yes po, Doc.
Yes po.
Gaganahan ba ya ako pag in-explain tapos di rin ngayon nababatian, ano? So, ulit lang. So, the first order neuron uses enkephalin. The second order neuron in this analgesia system uses serotonin. And then doon sa inhibitory interneuron, it uses enkephalin. So, these are neurotransmitter, enkephalin and serotonin. It can decrease pain. All right. So with the discovery of morphine, this was injected in the aqueductal area and periventricular area. It relieves pain, and that's why we know of this analgesia system. Eventually, they tried to discover some opiate-like substances, beta endorphin found in the hypothalamus and pituitary gland. We have metenkephalin, enkephalin, and that produced in the brainstem and spinal cord. But we also have synthetic drugs like morphine that can, and enkephalins that can relieve pain. Okay, inhibition of pain. So kung nasaktan ka, you are, there's a source of pain, and then yung jowa mo try to rub the surface of the skin, di ba? Somehow na-relieve yung pain. So the explanation behind is that the rubbing sensation stimulates the large type alpha beta sensory fibers. So it's a large type alpha beta sensory fibers. It's myelinated and it's large, so the saltatory conduction is faster. It will arrive into the spinal cord faster than the small alpha delta fibers. It's a spinal cord, ano siya, reception doon, one at a time. So kung nauna si large type AV receptor fibers, i-inhibit na si small type alpha delta fibers. So pain will be decreased or will not be perceived. And this is the explanation behind why rubbing from the skin after a pain stimuli somehow relieves pain. It is also the explanation behind how yung acupuncture can somehow relieve pain because of inhibition of pain transmission by simultaneous tactile sensory signals. Electrical stimulation can also relieve pain because, again, this is another tactile stimulus that is transmitted by the large type AV receptors of sensory fibers. It will be faster and will inhibit in the alpha delta fibers will be inhibited in the spinal cord. So you have probably heard about transcutaneous electrical stimulation. This is the explanation behind why electrical stimulation can somehow relieve pain. All right. So if the source of the pain is another area and you feel pain in another area, it's what we call as referred pain. And the explanation behind that, the visceral nerve fibers ends at neuron 1 and 2 in the spinal cord. The skin nerve fibers also terminate at neuron 1 and 2. So parehas yung binabagsakan nila in the spinal cord. The visceral nerve fibers are non-specific. It cannot localize the area of the source of the pain, whereas the skin nerve fibers are highly specific. It can really tell surface of the skin is there's a skin of the myocardium. Nagtitik na okay na? Di manawara, referred pain. Okay, so ulit sa referred pain. Okay, so if one tissue is the source of the pain, but you feel the pain in another surface of the skin, that's what we call as referred pain. And that's because the visceral nerve fibers and the skin nerve fibers have the same termination in the spine. So since visceral nerve fibers are non-specific, whereas the skin nerve fibers are highly specific and can really tell you, it can localize the source of the pain. So if there's ischemia of a certain tissue that is transmitted by the visceral nerve fibers, you can actually feel the pain in the skin nerve in the dermatomal pattern. For example, you have ischemia, if you have myocardial ischemia, hello? Hola? Hello?
Yes,
Okay, so you can sometimes feel the chest pain radiating in the shoulder area. Kasi nga parehas lang sila ng ng termination in the spinal cord. C5, for example, C5, di ba, on the right upper shoulder, left upper shoulder. C5 yan ang entry. So if you have chest pain, since left siya, kaya most of the time yung pain din is in the left upper shoulder. Kasi parehas sila sa C5. So yun yung explanation behind referred pain. And this is going to be helpful in diagnosing certain disease entity kasi for example, acute cholecystitis, the origin of the pain is in the gallbladder, and referred pain will be on the epigastrium or right upper back. So it can help you diagnose if you know the referred pain. Appendicitis, for example, have a referred pain in the umbilicus and the right lower quadrant. So if there's pain in that area, you will understand that the source of the pain is probably from appendicitis. So it's trying to help us. It will help us diagnose as to the source of the pain. Okay? Referred pain can help us diagnose the source of the pain. All right. So ito yung another explanation behind when visceral pain is referred to the surface of the body, the person generally localizes it in the dermatomal segment from which the visceral organ originated in the embryo, not necessarily where the visceral organ now lies. So it means to say, for example, the heart in the embryo, it originates in the neck and the upper thorax. So ganun din yung yung dermatomal pattern kasi yan in the heart ends in the C3 to T5. So you can feel pain from dermatomal areas from between C3 to T5. Ganun lang ang explanation nyo. So some patients can have referred pain in the jaw, in the neck, myocardial infarction to in the jaw, in the neck, in the shoulder, in the left arm. So ganun lang. Or if gastrium kasi from C3 to T5 siya. The stomach naman is between T7, for example, to T9. Kaya any dermatomal pattern involving T7 to T9 can be referred pain if there is damage to the stomach. Okay? Hello? All right. So last lecture, I talked about Brown-Séquard. And I realized, baka yung iba sa inyo familiar about this. Medyo mahirap-hirap siya na topic, no? But let's just try to explain a little bit more. So if there is a spinal cord injury sa buong spinal level na yan, let's say lumbar 1, then there will be loss of motor function from L1 down. Lahat yan, right and left. Kasi buong spinal cord ang affected. In the same way that there will be damage to the sensation from L1 down. Kahit anong sensation yan. From the dorsal column na sensation or the spinothalamic tract na sensation. Pero kung kalahati, yun ang magiging problem kasi mag-iiba ang presentation. Let's say only the left side of the spinal cord is injured, We call it Brown-Séquard syndrome. So there will be epsilateral one down will be affected. There will be epsilateral loss of proprioception, vibration, 2-point discrimination, yung pang dorsal column from the left L1 left side below. Epsilateral yun. Whereas contralateral ang loss of pain and temperature, and that's because dito at that level nagdidicusate yung spinothalamic tract at the level of the level of the spinal cord. Unlike yung dorsal column at saka yung corticospinal tract, doon kasi yan sa medullary area. Kaya ipsilateral, if there is Brown-Séquard syndrome, ipsilateral motor loss, ipsilateral loss of proprioception, vibration, and 2-point discrimination. Contralateral loss naman of pain and temperature. That's just how to help you diagnose a patient if there is a Brown-Séquard syndrome. All right. So let's now go, tapos na tayo sa pain. We shall now go to a little bit of thermal sensation. So there are receptors, and if these receptors can be excited, and based on the type of temperature. For example, on the extreme side of cold, freezing cold, then magiging cold, then cool. Tapos yung normal lang is indifferent, meaning hindi nag-change yung temperature, nandiyan lang, indifferent yon. But if you a little bit increase the temperature, it can be warm, and then farther it can be hot, then more than 45 degrees Celsius is burning hot. So, ganun siya. So, let's talk about cold. Pag between cold and cool, the cold receptors will be stimulated. But if it's beyond 15 below, hindi na yung cold receptors ang may stimulate, but pain receptors is stimulated by cold. Okay? So, ganun din sa warm and hot, the warm receptors will be stimulated, but more than 45 degrees Celsius, hindi na may stimulate yung warm receptors, but what will be stimulated are the pain receptors stimulated by heat. So take a plate, and that's why either burning hot signal sensation is these are the pain sensation, pain nerves, pain receptors. Hello? Can you hear me?
Yes, Doc.
Good, Doc.
Yes, Doc.
Okay. So the cold and warm receptors are located immediately under the skin at discrete separated spots. Warm signals are transmitted mainly by type C fibers. Para siyang slow pain, no? At velocities of 0.4 to 2 meters per second. While cold receptors are trending at velocities of 20 meters per second. Para siyang, yung sa fast pain. So magkaibang receptor ng cold, magkaibang receptor ng warmth, but ang freezing cold, ang burning hot, they are just the same, pain receptors. Kaya, if you are exposed to burning hot or freezing cold, the same ang sensation nun, painful siya. Spatial summation, malapit na tayo matapos. It only means to say that, for example, lumabas ka ng pintuan, konting change lang ng temperature because the entire body is exposed, you will feel cold. Whereas, yung meron kang yellow, ice, and then ilagay mo sa surface ng skin, kahit mas mataas yung temperature na yon, mas mababa yung temperature na yon, i-stimulate mo sa small surface ng skin, you will only feel the cold temperature on that surface area, but not in the entire body. Kasi nga, there is that number of cold or warm endings in any one surface of the body is slight. It is difficult to judge gradations of temperature when small skin areas are stimulated. Kasi if the more receptors are stimulated, the more that you will feel either warm or cold. But kung konti lang yung receptors na stimulate, only the surface area will feel cold or warm. Okay? So transmission of thermal signals. So from thermal receptors into the tract of Lisware and terminate in lamina 1 and 2 and 3. dorsal horns in the spinal cord, thermal ascending fibers that cross to the opposite side at that same spinal cord level and terminate in the reticular areas of the brain and ventrobasal complex. In the thalamus. Yay! Is this the last? Last na! Bakit hindi ako dumaan dito? No? Parang hindi ko to na-explain. Wait lang ha, balikan ko lang to. There is a visceral and parietal sensation. So good example here is yung appendicitis. So if there's inflammation pa lang, since mas malapit si visceral peritoneum to the appendix, then if there's inflammation to the appendix, the visceral sensory fibers will be stimulated. It will go to T10, and you will feel pain, referred pain in the umbilicus area. Pag medyo malaki-laki na yung inflammation, it will now stimulate the parietal pain. This time, the parietal pain will go to the L1, and this is more localized, more specific. So you will now feel pain in the left lower. So somehow it will help you diagnose a patient from acute appendicitis. Pag nag-change siya from umbilicus to the left lower quadrant, then you know that the inflammation is now bigger, or baka nag-rupture na nga yung appendicitis if the pain is now on the left lower quadrant. Nagiging mas specific na siya kasi pag umbilicus lang, malayo pa naman siya sa appendix. Unlike pag left lower quadrant, you know that the appendix is already in the left lower quadrant area. Ganun lang yung visceral and parietal pain. Okay. Questions? Hello? Yes. Mabilis ba? Sabi ko. Okay. So, pag Brown-Séquard syndrome, kalahati lang ng spinal cord yung injured, not the entire spinal cord. Let's say lumbar 1. Pag yung left side lang yung naapektuhan, left side lang, kalahati lang ng spinal cord, that's what we call as Brown-Séquard. Spinal cord injury kasi buong lumbar 1, buong spinal cord ang affected. So hindi tayo nahirapan sa pag-analyze kasi it means to say all motor and sensory from L1 below will be absent. Pero pag half lang, let's say left side lang, Brown-Séquard ang tawag niyan, magkakaibang manifestation. Meron kang ipsilateral manifestation, meron kang contralateral manifestation. So if we talk about Brown-Séquard syndrome L1, yung left side ang affected, there will be ipsilateral motor loss. Meaning to say from L1 below on the left, wala kang motor, pero sa right meron ka. And then ipsilateral loss of dorsal column, yung proprioception, vibration, 2-point discrimination, from the left of L1 down below. Sa right, wala kang loss of proprioception, 2-point discrimination. Pero yung spinothalamic tract will be lost contralateral. Left ang affected mo, left na L1, ibig sabihin from L1 and below on the right side, halos wala ka naman yung mga tactile mo, crude touch, temperature, mga ganyan. So sa right ang maapektuhan from L1 and below, opposite, contralateral. And that's because yung spinothalamic tract it decussates on the level of the spinal cord, whereas yung sa dorsal column and corticospinal tract nandoon sila sa medulla. So for example, the damage is in the left hemisphere, no? Left hemisphere. Contralateral naman ang motor loss. Magiging contralateral ang motor loss mo ng right side ang affected mo, there will be contralateral. Left side naman ang motor function affected. Left side din ang sensory function. That's because the dorsal column and the corticospinal tract decussates at the medulla area. Naku, siguro mas maiintindihan nyo siya pag may drawing, kaya lang wala tayong drawing, no? Kasi for example, kung mahaba na sa corticospinal tract ako, nasaan yung cut mo, nasa kabila yung affected kasi nandun siya nag-decussate sa medulla. Pero ang problem sa Brown-Séquard, because if you cut that level, yung left side, no, yung spinothalamic tract, nasa kabila yung maapektuhan kasi nag-decussate siya at the spinal cord level. Ipsilateral naman sa sa dorsal column and corticospinal tract. Oh, at this level, alam mo yung ng first year ako, di ko maintindihan yan kahit anong gawin ko. Ang ginagawa ko na lang, minimemorize ko na lang muna. So, Brown-Séquard syndrome, ipsilateral, motor loss, ipsilateral na dorsal column, meaning to say vibration, 2-point discrimination, mga ganyan. No? And then contralateral naman, yung crude touch, temperature, mga ganyan. No? Yung pang-spinothalamic tract, contralateral. So, if the affected is the left side of the spinal cord, the left, there will be left motor loss, left loss of vibration, 2-point discrimination. Nasa right naman ang pain and temperature na affected. Ano? Pag right naman na spinal cord level ang affected, right ang motor loss, right ang right ang vibration, 2-point discrimination, pero nasa left ang pain and temperature na affected. Huh? Nakakaloka, no? Stroke talaga itong girl. So kung stroke ka naman, dito ka naman brain liwat, which we will talk about in the next few chapter. If the left pala, dapat left kasi most common kasi left, no? Left hemisphere is affected, ang motor loss is nasa right, contralateral. In Brown-Séquard, ang motor loss is ipsilateral. Yun yung pagkakaiba, no? Nakakaloka. And the explanation is because of the decussation, yung pag-cross. Kung nasaan siya nagko-cross, left side, ang na-affectan mo na brain, nagdi-decussate siya doon sa medulla, kaya right side ang motor loss. Diyos ko dahil, stroke ka dahil dyan. Kaya hindi mo siguro pa yan. Some of you have very good, yung na memory in terms of ina-imagine nila. Pero most of you, i-memorize nyo na lang Brown-Séquard syndrome, ipsilateral motor loss, ipsilateral loss of dorsal column sensation, yung light touch, 2-point discrimination, vibration, proprioception. And then contralateral loss naman of spinothalamic tract, light, crude touch, di ba? Pain and temperature. Ganun. Contralateral. Na-stroke na ba kayo? Bakit pag ngayon, okay na ba? Did I answer your question? I hope naliwanagan kayo. Some more question? Kunti lang siya yung chapter na yon. Kahit pang third year ko na to na nagle-lecture ng chapter na yun, yung confidence ko, no? Hindi pa rin ganun ka. Cardiologist ako, no? Siguro kung cardio yung topic, may lang talaga, no? Confidence lang. Question, come more. Confidence lang. Pero pag neuro, Diyos ko Lord, parang biochem lang, no? Kahit aral na ako, pero sorry, I'm in the hospital, so may mga ingay. Naririnig niyo ba yung prompt? Gaganunin ko na lang yung prompt. Question? Do you have a question? Vaccination kasi ngayon. And mava-vaccinate na ako ngayon. And then after that, magbabantay naman ako for adverse drug reaction. And that's why we are chaotic in the hospital. Chaotic talaga, no? Kasi daming mga taga-RTR graduate ngayon. Naglilipa na ang mga RTR graduate. Ano alam niyo kung ibig sabihin nun? Yung mga maa-RT, we call it RTR graduate. Kasi, di ba, hanwaray pa vaccine, parang, Lord, sana dumating na yung vaccine, sana ma-discover na yung vaccine, please, Lord. Tapos sa ng vaccine, dawan mga RT. Ayaw na magpa-vaccine, kesyo, papabuntis, baka makasama yan, makakos ng impotence, baka lugod hiyama COVID. These are mga RTR graduates. So, Daming arte, no? Anyway, arte graduate din ako kaya may karapatang mag-inarte. So, question? May tanong ba kayo? Nagiging joke namin yun, no? Dahil RTR graduate, pasyente. Room 1, RTR graduate. Ganon. May tanong pa ba kayo?
Doc,
Ah,
can you hear me, Doc?
yes, I can hear you. Para kang...
Doc, I have a question. Ano,
Yes.
di ba there are some patients who are hypertensive but they don't feel any pain at all? Does it have something to do with pain tolerance?
Hypertensive?
Yes, Doc. Or someone who has hypertension pero
Yung tapos di ba yung nagnunucal pain sila?
they don't feel anything. I mean, does it have something to do with pain tolerance?
Gusto ko sanang sabihin, baka, yes. Pero they tried to do a study on that. There's no correlation. Kasi nga, pag mataas ang pressure mo, for it to cause pain, it's either the intracranial pressure should increase or the vessel wall should be an increased pressure to the point that the vessel wall can stimulate the vessel wall. That's the only time na makakaroon siya ng pain. Your internet connection, nga sa midok. So wala daw correlation in terms of hypertensive patients who feel pain and those hypertensive, like to say that it's probably because of the analgesia system, pero hindi siya correlated sa hypertensive patients. Doc, do we have a quiz tomorrow with physio? Bakit? Nakaschedule ba bukas?
Oh, Doc, on March 18 pa po.
Oh, March
O
18.
17 po.
Pakalas man ini neurophysio. Si Elacion Alfredo. Yung call ba ako? Parang waray pa ako na-inform na may quiz. Parang matagal pa yung quiz nyo, don't worry. Yung door, no? Wait lang. Do you have a question? Nabawasan ba? Do you have a question? Okay. Kasi yung sa yung sa head, yung sa hypertensive patient, big kasi yung pain. Hindi siya specific, no? At saka walang correlation yung pain sa hypertensive patient. Ibig sabihin, some hypertensive feel pain, some hypertensive patients do not feel pain. Pero yung nararamdaman nilang pain sa nuchal area, hindi siya, hindi mo sasabing, Doc, masakit yung batok ko, mataas ang batok, normal. Sakit naman ang batok, pag BP, mataas ang BP. So it's not really predictive, not correlated siya. I hope I answered the... Di ba kayo happy? Happy ako noon when I was a student, tapos nababawasan isang chapter. Nakakaloka kaya magbasa ng... Any more question? Going on? Going twice? Going thrice? Tama ba? Thank you very much. Wala na? Goodbye na tayo?